Today we will discuss about an interesting case. The name of the topic is an atypical phase of lupus, nephrotic syndrome progressing to acute renal failure at initial presentation. We all know systemic lupus erythematosus or SLE is a prototype autoimmune disease. Renal involvement is more common in children as compared to their adult counterparts. Lupus nephritis is usually a slow process that may lead to renal failure months or years after its first or initial presentation. In this case, we describe a girl with lupus whose initial presentation must go then as nephrotic syndrome. She was an 8-year-old girl, first born to a non-consanguineously married couple, presented with anasarca and oliguria for 7 days. In basic workup, we found there was 3+ proteinuria and RBC number was 4 in urine microscopic examination. Urine protein creatinine ratio was 4, serum albumin was 1.5, cholesterol was 256 mg per deciliter. So we were thinking it as a case of nephrotic syndrome, but gradually she developed hematuria, there was hypertension and more prominent oliguria. So we found the hemoglobin level was 7.8 gram per dl, platelet was 94,000 and collected retic count was 2.4%, direct Coombs test was positive. Urea creatinine level was 70 and 1.9 respectively. Then her mother said that she was suffering from joint pain or arthralgia for last 1 month, involving multiple large and small joints. So we have sent anti-nuclear antibody, anti-dsDNA and C3C4. The anti-nuclear antibody was 3+ homogeneously positive, dsDNA was raised and there was hypocomplementemia. So, but the renal function of the patient was gradually deteriorating. Her urine output was becoming less than 0.3 ml per kg per hour. Her urea creatinine level was raised from 70 and 1.9 to 140 and 2.3 respectively. So we have started pulse dose of injection methylprednisolone at 30 mg per kg per day for 5 days. Initial dose of injection cyclophosphamide 5 mg per meter square body surface area. After those, the child was gradually recovered from renal failure. And we have done renal biopsy for her. Based on the clinical findings and laboratory findings, according to Euler acid criteria, the total score was 38. So we have already diagnosed it as a case of SLE. Subsequently, we have done renal biopsy, which showed features of class 5 lupus nephritis. Here is the picture: class 5 lupus nephritis or membranous lupus nephritis. Initial doses, the child gradually recovered from renal failure. Then she was asked to continue on monthly injection cyclophosphamide and oral prednisolone with gradual tapering, along with hydroxychloroquine tablet and photoprotective measures. At 6 months follow-up, the child is doing well with complete remission. So we can conclude that nephrotic syndrome with acute renal failure can be an atypical initial presentation of childhood lupus. SLE should always be considered in the differential diagnosis of a girl with nephrotic syndrome. Prompt diagnosis and aggressive treatment can be life-saving. Thank you.